Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who attended with a severe bilateral earwax impaction that was not only causing them hearing loss, but otalgia, so ear pain, and also pain radiating all the way around the right side of their head. And I've just reduced the brightness of the WAXscope because this wax has got a high keratin content. So keratin is a protein that's found in the outermost layer of the dead skin cells that line the ear canal, and the shedded skin cells from the ear canal actually amalgamate with natural oils and sweats our ears produce to form earwax. And keratin is highly reflective. One of the benefits of keratin actually is that it helps to reflect harmful UV sun rays. So because this wax is right near the entrance, this lateral segment anyway, and the WAXscope is used to dilate and stretch open the ear canal, the brightness from the light source of the WAXscope reflects off the keratin and you can get a glare. So I've just reduced the brightness, and as we go deeper, I'm just increasing the brightness because we're getting less glare. As you can see, I've installed quite a lot of medical grade olive oil spray here just to soften the surface to get a grip. Now this patient has got quite a lot of matted hairs as well. I was reluctant initially to use any manual instruments, so ear hook, Jobson horn, because as mentioned right at the beginning of the video, this patient was experiencing severe ear pain, and you're much more likely to exacerbate that pain by introducing an ear hook or correct. When you're performing microsuction, you can try and remove the plug by positioning the suction probe, as you can see, the suction tip, onto the lateral surface of the wax. You don't have to go anywhere near the canal walls. And because this is fully occluding, and you're going to see it now, when we introduce an ear hook, you are going a bit closer to the canal wall, so you can exacerbate the pain. And one of the benefits of the right angled ear hook is what we're using here. I've tapered the tip, which allowed me to penetrate, but when you penetrate into the wax plug, you are applying a bit of pressure. So again, that can exacerbate the pain. Fortunately, the patient was fine on that occasion, but although the ear hook didn't remove the plug of wax, it did dissect it. So it's kind of breaking it up, which I'm now going back in with the suction probe, just trying to remove this, and you can see it's more mobilized. I think I had to revert back to the ear hook in a moment, but this plug is extending all the way to the patient's eardrum, and our ear canal are not cylindrical tubes. It'd be great if they were, because it will make earwax removal a lot easier. But as we enter, so this is the patient's right ear, so as we enter the ear, you're almost going in initially around 1 or 2 o'clock, and then when you approach the first bend, like we just did there, we're then rotating the WAXscope back towards, say, 11 o'clock to stretch open that first bend on the left-hand side. Then you enter about 0.5 centimetre into the ear canal, and then you rotate the WAXscope back to about 12 o'clock. So you're having to stretch and dilate the ear canal. And the narrowest part of the ear canal is in between the first and second bend. So the average length of the human's ear canal is about 26 millimetres. So that first bend is about 5 millimetres into the ear, and the second bend is about another 5 millimetres beyond that. And so this plug is stuck in that, in between the first and second bend, that narrowing. We call that an isthmus. So quite often you can mobilize the wax plug, bring it forwards, and then it gets trapped in between that first and second bend. Additionally, with a plug like this, which extends all the way to the eardrum, there is a second narrowing, just about 0.5 centimetre away from the eardrum, where the ear canal narrows and then widens again. So if you get wax pushed into that region of the ear canal, so either using Q-tips, cotton buds, or hoppy ear candle, which this patient did, it can also get trapped in that second deeper narrowing. So earwax can be very difficult to remove. It may not always appear it when you're watching videos, but when you're actually performing the procedure, it's a nice healthy eardrum. So moving on to the left side. So with the left ear, when you enter the ear, initially you're kind of going in about 11 o'clock, then using the specular to push the first bend, which is now on the right hand side, back to 1 o'clock, you go in slightly and then you rotate the WAXscope back to about 12 or 11 o'clock again to straighten the ear canal. So I immediately put some medical grade olive oil spray because we did so on the other side and it really helped. So I'm just sizing up the top part of the ear canal because I'm going to use the hook a bit sooner on this side. And we're just going to, I'm not going to go too deep, I just want to penetrate. There we are. So the tapered tip of the hook really helps. The important thing when using ear hooks or curettes or the ear pick is that when you do penetrate and you extract forwards, you don't want to dig in too deep because you run the risk of then scraping the floor of the ear canal. So, and then again, that's where having an awareness of the ear anatomy is really important. So when you're experiencing the ear, you kind of know how deep and how not too deep to penetrate. So again, the hook hasn't removed it, but I kind of sliced this wax up and I'm just separating it from the back canal wall. And again, to the left now, that's the second bend, that flesh. So I'm just bringing it past the second bend. So this is the isthmus, this is the narrow part now. I am using the specular to kind of stretch open this isthmus as much as possible. And we're just going to rock this out now. There's a big boulder. On this side, the eardrum is fine, but the umbo, which is the section of the hammer bone, the malleus that connects to the eardrum in the center, kind of think about it like the bullseye on a darts board. It just looks slightly remodeled, so it hasn't got that same kind of spherical shape. You'll see what I mean in a moment. It's nothing to be concerned about. Patient's not experiencing any hearing loss, but that might just be the patient's natural anatomy of the hammer bone. It could have gone a process called remodeling where the bone remodels itself. So I'm going to get that center bit in focus in a moment. And you can see it's with the right side, and they've got a slight attic retraction, but that umbo where I'm focusing on now, normally it's a bit more round. So it might have gone through a process of remodeling where the bone reshapes itself. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.